The pulse pressure that you are feeling when you check somebody's pulse, right? That is that pressure of the ejection of blood against the vessels. The mean arterial pressure, or the is the average pressure within the arterial system that is felt by the organs. This is not the average of the diastolic and systolic pressures. Okay, so MAP is not the average of the systolic and diastolic. It is the average of the pressure that the organs are feeling. The MAP is calculated, and you will not have to calculate MAP in this class. MAP is calculated as systolic divided by 2 times or plus 2 times diastolic divided by 3. Yes.
So with the MAP, you're saying it's the pressure that the organ feels, you mean like the blood that's going into the organ that's
correct. That's what, and we want MAP greater than 60 in order to ensure perfusion. So the lower the MAP, the least perfused the organ is. So if the, and when you look at it, you're looking at the monitor and it's like, here's the blood pressure, and then there's the small number next to it. That is the calculated MAP by that machine. Usually it is above 60. But if you see a lower number and the longer that number is low 60, that those organs are not being perfused. These vital organs that are underperfused for an extended period of time, they can and will become ischemic. That is a problem. We need our organs to be perfused, including brain, our kidneys. Our kidneys are whiny little babies. They have to be perfused. About 1/3 of our blood supply goes straight to the kidneys after the heart. They're whiny little babies. I'm telling you. Okay, some gerontologic considerations. People that are higher risk for cardiovascular disease. Cardiovascular disease, if you guys will remember, is the leading cause of death, age, the cardiovascular changes. And we have less physiologic reserve, meaning if we're talking about cardiac output, and they have one massive GI bleed and they poop out a bunch of blood, that is going to impact them a lot more than, say, a 40-year-old adult who does the same thing. That less physiologic reserve is going to make it so they're just not able to tolerate that as well. Other age-related changes impact to the relaxation contraction. So that ability for the heart to relax and contract as effectively as it was before, it's not able to. The response to stress. So think about how you want somebody to be able to run up some stairs and run back down and then just reset. The body doesn't do that as well as it did before. Heart valve changes. Our heart valves become a little more rigid and less pliable. They lose that ability to function as it did before. Pacemaker cell changes. That's why as somebody ages, they're more likely to have challenges like AFib and a flutter. The beta adrenergic receptors are not as effective. Blood vessel changes, our blood vessels don't contract as effectively as before. And then with blood pressure changes, there's orthostatic hypotension, as well as postprandial hypotension, which is a decrease of blood pressure of 20 millimeters of mercury or more within 75 minutes of eating. So that postprandial hypotension is low blood pressure within 75 minutes of eating. And then the venous valves are not as efficient at closing and forcing blood to return. So how do we assess our patients when it comes to cardiovascular system? Thinking all the way back to first semester when you guys did your health assessment class, this is going to be your basic health assessment stuff. We're thinking back to, hey, tell me what's going on. Are you feeling normal? Why are you here? What is your current status? Are you taking any medications? Were you taking medications? Have you had surgery? Are you expecting to have surgery? Anything that's related to what's happening to them now. When it comes to functional health patterns, what is going on when it comes to your coping, your stress tolerance patterns, values, beliefs patterns? This person willing to have blood products, especially if they are a potential for are they bleeding out? We want to know that. Role relationship patterns. We do always want to be asking, are they the sole care provider? This is somebody who just had a massive cardiac event, because that can be really stressful if they're trying to think about healing and they're also thinking about what do I have to do when I get home? Those are very stress inducing. So when we're looking at our physical exam, obviously our vitals are going to be one of the first things that we're going to look at. Our peripheral system, inspection, palpation, auscultation. What exactly are we seeing on our patient? Now, remember that when we walk into a room, all of our senses assess our patient, right? Sometimes our sense of smell assaults us before we ever see our patient. Anybody taking care of GI bleed or C. diff patients, and you know that's what they are before you even walk into the room, right? You're like, oh, okay, how to get ready for that, right? When you start to assess your patient, if the first thing I see is the patient who's covered in bruises, that starts to give me some clues, right? Or my patient who's standing there and they're like, hey, yeah, nice to meet you. Yeah, I'm fine. I'm okay. Yeah, I'm good. Anybody worried about that patient? Or the patient who's just sitting there on their phone? How you doing? They all give you a different perspective as to what's going on with them, right? So, common sense for assessing pulses when we are concerned about our patients who have a cardiovascular issue. We do want to assess bilateral pulses, never bilateral here though. Please don't remember, right? For assessing bilateral here, no bueno, okay? Bilateral radial, no problem. Bilateral femoral, you can even do that. Might be a little weird. You might think that's a little awkward, but you can do it. So as you're heading down to the legs though, what else can you assess as you're assessing the bilateral, like do papa too, but bilateral dorsalis pedis pulses. What else are we assessing down on the legs? Edema, yeah. Edema gives us good information, right? Temperature. What else gives us good information down there? Color. What else? We got temperature, color, muscles. Also, skin. And hair. You ever seen those, I know y'all have, standing in line at the grocery store and you're like, what a strange looking situation down there, right? And there's like patches of hair missing on the man. For obvious on men. Sorry. And you're like, that is really interesting. He's just missing this whole patch of hair. Maybe not quite discolored yet. He's missing a whole patch of hair. Not from his socks. Not because he wears his socks weird. It's because he's not getting circulation to that area. So gives us tons of information. Don't forget about our anatomical landmarks when it comes to listening to cardiac sounds. Our mitral valve location and PMI. That may or may not come up on a test question. Intent, wink, wink. This beautiful spot right here. Mid-clavicular line with intercostal space. When you are physically touching your patient, you can feel pulsations with the tips of your fingers. That's why we check pulses with the tips of our fingers. You can feel thrills with like the bottoms of your fingers, the top of your palm. And then you can feel heaves or lifts with the bottom of your palm. So if you have a patient who is having, so sometimes you can actually feel it at the PMI if they're like very, their heart rate is very aggressive. You can actually feel that. You feel the thrill. And you can feel the thrill here. It's not great. You don't want it. Okay. This will be gone over in much greater detail on Tuesday next week, but very quickly. This is where heart sounds lie on an EKG. So S1 is during the QRS, and S2 is at the end of the T wave. And then systole happens during the T wave, diastole happens going in the end of the T wave, going into the T wave. And that will, like I said, there'll be much more of that during Professor Fraser's lecture on EKGs and on Tuesday next week. Okay, cardiac biomarkers. We love our labs when it comes to cardiac. Okay. Generally, you will just hear the term troponin, although troponin is broken up into different types. Just troponin is one of the ways that we check for cardiac muscle damage. The best way in my brain to think about how troponin works is think about a capsule, a medication capsule, and how inside the capsule is all those teeny tiny little pills or little like balls sometimes when you look at the capsule. When cardiac muscle is damaged, that capsule breaks open and it spills troponin into the bloodstream. The more cardiac muscle that's damaged, the more capsules break open and spills troponin into the bloodstream. Okay? You do not need to know troponin T versus troponin I. Just understand that troponin is what we measure for cardiac muscle damage. It rises within 4 to 6 hours, peaks at about 12 to 24 hours, but can be detected for up to 14 days. High sensitivity troponin is what is used across the board in the emergency room. We're checking it as soon as somebody comes in. complaining of chest pain. Now, just because their troponin is not elevated does not automatically mean they're not having a cardiac event. We love to see an elevated troponin and EKG changes because that's a slam dunk straight to the cath lab. But it doesn't, a negative troponin does not rule out cardiac automatic. But this is our favorite. Now, we also have other ones. We have creatinine kinase, CK. There's 3 different types. There's MM, BB, and MB. CKMB is cardiac specific. This is the one that we're watching. If we're going to order a cardiac panel, it would be troponin, CKMB, and myoglobin. And these are the ones that we're checking because they're specific to cardiac muscle. When that cardiac muscle is damaged, we're going to see these start to elevate. And they all elevate differently. So you can see the different times for how long they stay elevated. So myoglobin is like, bam, I'm going to elevate right away. But then I'm going to go down and you're not going to see me. So if somebody comes in and says, I had chest pain 5 hours ago, they may not even hardly have myoglobin elevated at all. It's already on its way back down. Troponin is on its way up. CKMB is like, oh yeah, I'll start to come up, right? So, but if they're gonna order anything, troponin is our go-to. Other things that we may measure, C-reactive protein, CRP, homocysteine. They may check other dietary deficiencies like vitamin D levels, whatever, but typically not in the ER. Those would be like later. For other studies, cardiac natriuretic peptide markers, specifically the B-type natriuretic peptide, a BNP or BTNP. They're interchangeable. If you hear me say either one of those, they're the same. This measures if our patient is in congestive heart failure or not. The other ones we don't see used as much. Now, those all can be done at any point in time, do not require any special timing. Lipids, cholesterol, phospholipids, triglycerides, all of that, that has to be done and measured when a patient has had, when they've been fasting. So these are not done on a patient who comes into the emergency department. We're not gonna be like, yeah, let's pull a labs for their lipids. Absolutely not. Now, does a cardiac patient need these checked? Yes, but not emergent. We also look at triglycerides, LDLs, HDLs, and then total cholesterol levels. This right here is the risk calculator. You guys, it's a live link if you guys wanted to check and see what your cardiac risk calculator is. This one actually is my husband's. Yes, he knows I use it. So he has a 3.9% 10-year chance of cardiovascular disease, with a 4.4% chance of heart failure in the next 10 years, but a 26% chance in the next 30 years. Well, he's 51, of course he is. 10-year chance of 10-year chance of cardiovascular disease is 6%, and then 33.2%. So here he has a stent. So I feel like those numbers should be higher, but anyways. So it's interesting. It's based on age, sex, race, blood pressure, total cholesterol. So if you want to figure something in. Okay, other diagnostic studies of cardiovascular system. This is a chest x-ray. We're gonna get this on everybody. Hey, this is only gonna tell us is the shape of the heart okay? Does it look okay? It'll give us big landmarks. It's gonna tell us if the lungs okay. Because that's what lungs and heart, they are hanging out there together. They are very intimately related. Cerebral effusion, anything like that. Not gonna give us specific inside the heart issues. Okay. And the echocardiogram. No, electrocardiogram, that goes next. ECG, EKG, we want a 12 lead. What does that look like? How is that working on our patient? So there's the 12 lead that you have the paper. They're like, hey, how's this 12 lead, right? There is the 3 lead that when you have a patient in the emergency department, you have your 3 little leads on and they're up in the monitor, right? Anytime you hit print, that is a 6-second strip of what is happening with your patient. Okay? That is just a snapshot in time of their electrical activity of what's going on with them. You don't know the before or the after. It's just what you have captured in that 6 seconds. It can change massively in time, right? We know patients don't like to follow directions. They're not going by the book. But either way, we also have the ability, because patients change, to do ambulatory EKG monitoring, also called Holter monitors. They used to be these big complicated things. Now they're like these little like palm-sized things that remote monitor. It's amazing. They can go anywhere from 3 days to 30 days. The patient swears to find out. They may report to their cardiologist. I've been really struggling with feeling short of breath. It's like my heart is racing. So the cardiologist puts them on that and they get to see how that feels or what's going on. A VEC monitor can be combined with ambulatory ECG monitoring. In that case, they're actually pushing a button whenever they feel that. A loop recorder is the same thing, but it's implanted. And they're not saying when that happens. Exercise stress or chemical stress testing, we're going to put you on a treadmill or a bike, and you're going to work, bring your heart rate up. We're going to have you on the EKG. We're going to monitor everything that's happening to you during that time. Chemical stress testing, you can't handle being on a bike or a treadmill, so we're going to give you medications to bump that heart rate up. Make you feel really, really lousy. Will we chemically make your heart go crazy? I'm going to watch what's happening during that time. An echocardiogram, this is the ultrasound of the heart. They can with or without contrast. Usually they'll do both, so they can see what's happening. This is where we're going to measure the ejection fraction of what is actually being pumped out. They can do a stress echo, which is that stress test, but they're actually doing an ultrasound at the same time. A transesophageal echo is they are putting a tube down the esophagus and doing an echo of the other side of the heart, but they can't get a good visual on from the outside. Here's some pictures of the echo with and without contrast. There's also an echo called a bubble study, where they inject air into an IV so they can see whether or not there's holes in the chamber of the heart. Yes, you can inject air. It's not scary. Nuclear cardiology, this is a MUGA scan. Stress imaging also can be done during this time. There's cardiovascular magnetic resonance imaging, and then there's CT, the cardiac. And they are checking calcium scoring, checking angiography, all that stuff. Here is one. This is actually showing calcium deposits with the left anterior descending coronary artery. So this person probably ended up with a stent after this. Right, cardiac taps. This measures the right side for pressures. So if a patient has their concern for like pulmonary hypertension, that's where they would go and measure the right side for pressures and then left side to evaluate coronary arteries. They can go in either the wrist or the groin. Wrist is a lot easier. And coronary angiography uses contrast medium to check for blockages. So here we can see a blockage. It's not able to go any further. And then here we have the blockage, and then afterwards, once they can put that stent in, it's like boom, now it's wide open. And they do it same time. They go in, they check the blockage, and then they open it. They can do an intracoronary ultrasound. That's where they're in there and they're measuring it at the same time, or they're ultrasounding it at the same time. There's a fractional flow reserve where they're using special wires to measure pressure and flow of the coronary arteries. They'll do that along with when they're doing the angiography. And then electrophysiology study. This is looking at the cardiac conduction. So specific for our patient who has AFib, A-flutter, if they're having runs of VTAC, they'll use electrophysiology. That's a whole separate cardiology study specialty. So when it comes to teaching our patients healthy heart tips, this is our patient we want to lower sodium intake, stop smoking, keep blood pressure low, get active, exercise, drink less, lose weight when possible, cut the fat, get good sleep, all that good stuff. We have a lab day tomorrow, 8 to 5, Sim Center, red and blue scrubs. I end with food for thought. How does signs and symptoms differ between right and left side heart failure? We will start that on Wednesday. Let me pull up real quick the show you guys the canvas stuff.
So.
So you go to your state Blackboard page and you can log in at Canvas from here. Red ID. And so everything's left here. Here's our Canvas colors. And this should all look the same for you guys, right? All your good things. Now, something to keep in mind for Wednesday, there is a class quiz and a questionnaire for heart failure that needs to be done before class on Wednesday. You can find your syllabus here. It also gives you how it's graded. And then all the way down here gives you a list of the course summary. So when things are due and the time, which is really nice. You have it out all in one spot for when your assignments are due. For modules, course overview, some information, obviously your syllabus and stuff there. Some ideas. This is where the class point access code is, as well as if you don't have your oral health, I can't imagine that you don't. Just to let you guys know, every exam that I have, you are allowed these med cards. They are 4 medications per page. You have 2 of them. Fill them out. I give recommended medications for them on the study guide. So it's a little hint for exams. Don't do specific medications, do drug classes. So here's what I do. I have your content with some learning objectives, your to-do list. The best way to work through Canvas is to do next. Because that's going to take you through each of the things. Once I did get some of today's lecture recorded, so I'll post the recording here. I want to go back and listen. Here's some information. Here's some extra stuff to listen to or to go look at. Some are recordings. Some are YouTube links. This is a little thing on antihypertensive stuff. The next will take you to the heart failure. Well, this is my version of it, but that's the questionnaire. It's just some questions on what do I know about heart failure? What do I want to know about heart failure? And I can't remember the other ones. So there's like 3 little questions there and then some questions about, then the next one is, I think 5 questions on heart failure. I don't care if you study or not for the heart failure quiz. It truly is how well do you know heart failure? Because you're going to take the exact same quiz after we go over heart failure on Wednesday. And I want to know, how well did you do? Like, did you take away good information after you had a lecture on heart failure? Okay, so don't worry about it. So I want you guys to be able to really utilize the information that is within here. I have a lot of information on my PowerPoints. Some people find that too overwhelming to their brains. But I do post all of my PowerPoints. So my faculty version PowerPoints are there for you guys. I would still encourage you, even if they're too much for lectures, to read my notes in my PowerPoints because they have a lot of good information in there. So, hint. Here's information on your PassPoint stuff. How to log in. We have a new version of PassPoint. So when you guys go and click into PassPoint, it's the second little box and it has like a new and a star on it. So make sure you're logging into that one, not the other versions. Let me know if you have problems with that. Okay? Any questions about Canvas? And when you guys go and look at your grades, you should be able to see everything. It should all be nice and clear. I love Canvas so much. I think it makes so much more sense. Okay. See you guys tomorrow. Right?